to the first part of a three-part series on adhesive capsulitis. Today is the first episode of Unfreezing the Truth of Frozen Shoulder, also known as adhesive capsulitis. We also have part 2 on the physical rehab and part 3 for the intervention of adhesive capsulitis. So make sure to check those out and stay tuned for this exciting three-part series on frozen shoulder. Today we have Dr. Philip Peng, a professor in anesthesiology and pain management at the University of Toronto. Let's go find him.
So, Dr. Peng, tell us, what is adhesive capsulitis?
Adhesive capsulitis is a disabling disorder of the shoulder characterized by both pain and progressive loss of both active and passive movement of the shoulder. I want to emphasize is the loss of both active and passive movement that differentiate from many other painful conditions where mainly the active loss of range of movement. In 1945, Julius Naviesa, the senior member of the Naviesa family, the big family with a lot of shoulder surgeons, he used the term adhesive capsulitis. I think it's a better term because it reflects the underlying pathophysiology, especially the pathological fibrosis better. It tends to affect those between 40 to 70s, peak around 50, and as a matter of fact, it's so common in those patients who are 50 years old. In some Asian countries like Japan and China, they call this condition called 50 years shoulder.
That's so interesting, but I don't understand. Who tends to get frozen shoulder?
So I already mentioned about age. Gender is another one. Around 2/3 of the sufferers, they are female. Diabetes type 1, type 2, and hypothyroid, they are the risk factor. Especially diabetes type 1, type 2, they tend to increase the risk 2 to 5 times, also with a worse outcome, a poor outcome. Parkinson and also the stroke can increase the risk, and I think probably related to the lack of mobility. There's some clear secondary cause like a shoulder trauma in which with the pain, patient usually immobilized for some time. But I think the key message is when you have the shoulder injury, mobilization is the key. You need to mobilize early, otherwise you get frozen.
But I just don't understand. What's going wrong inside the shoulder that actually makes it frozen?
Well, we don't have the whole picture, but the literature is quite clear that the whole process starts with inflammation. And from there, there's a lot of release of pro-inflammatory cytokine. And from there, it leads to the fibrotic process. In the process of a fibrotic proliferation, there's some dysregulated collagen synthesis, as well as enhanced contractility of the fibroblast. We call them myofibroblasts. This process leads to capsular thickening and contracture at different stages. The fibrotic process affects both the intra and extra articular tissue, such as the coracohumeral ligament. As a result, there is a profound stiffness of the shoulder. Recent literature shows certain chemical mediators, such as transforming growth factor TGF-beta or intracellular adhesion molecule ICAM1. They are upregulated, resulting in the proliferation of the fibrotic process. And those chemical mediators usually seen in chronic inflammation. And guess what? Diabetes and thyroid, they are the condition associated with chronic inflammation. It explains the link between the frozen shoulder and the diabetes. As a result, there's contracture of the capsule and thickening of the coracohumeral ligament and change in the rotator cuff interval. Notice the change is not just inside, but also outside the capsule, more in the pericapsular manner.
So all the stiffness is because of the thickening and contracture of the capsule. Am I correct?
Mostly correct. There is an interesting study show that muscle stiffness or guarding can be a factor. In that study, they subject those patients with frozen shoulder under general anesthesia. They examine the range before and after, and this is what they show. They show that there is an increase in around 50 to even 110 degrees of movement after anesthetic. So what lesson we learn here? There are two. One is the underlying muscle guarding can be related to the inflammation or pain, and sometimes we need to alleviate the pain to improve the outcome. The second is there are some psychological factors that can cause the muscle guarding, such as fear avoidance, or in this study, show catastrophizing can be a factor. So we need to manage the patient accordingly to adjust the psychological factors.
So if I think I have adhesive capsulitis, how would you diagnose it?
It's still mainly a clinical diagnosis when the patient have shoulder pain and progressive loss of the active and passive range of movement. Classically, the pain initially is very intense. So they are there all the time, even at rest, and any movement will cause pain. They can happen at night, sometimes keep you from sleeping. You cannot sleep on the shoulder. When the pain starts to come down a little later, you get a little bit better, but then the fibrotic process start to go up and the patient will start to have some stiffness. The typical stiffness start with the anterior capsule, so they have a lot of hard time in we call external rotation. They usually complain that they are not able to wash their hair properly or touch their hair. And then later on, they may have some difficulty. We call internal rotation, try to touch the back. And for women, they may have a hard time in tying their bra. With time, they also notice there's some difficulty in abduction or forward flexion. So instead of just moving the arm like this, they just cheat a little bit by swinging the scapula and lift the shoulder up like this. So it's typical you see someone move the shoulder like this in order to reach some overhead object. And with time, they overuse the trapezius muscle, and that's why they may have some myofascial pain of the shoulder.
So the diagnosis, it's fairly straightforward, isn't it?
Not really.
Oh no.
So there are some other shoulder condition can mimic the symptoms. One good example is the shoulder osteoarthritis, especially when it's advanced. They have the stiffness and have a loss of both active and passive movement. Even the rotator cuff disease, when they have we call associated arthropathy, when it is advanced, they also have some increase in passive loss of movement. So some investigators try to find out how reliable is the clinical diagnosis and find that the inter-observer agreement is only moderate. There was an attempt to improve the clinical diagnosis by highlighting some clinical identifiers with the Delphi consensus between different physicians and clinicians. But when they try to validate those clinical identifiers to diagnose the early adhesive capsulitis, the conclusion is that those identifiers are not very reliable. Therefore, in some difficult cases, I think there's a role for imaging to help the diagnosis.
What imaging are you referring to?
The short answer is MRI, but in the family practice, you cannot just everyone with adhesive capsulitis, you just have the MRI. I think it's very reasonable to ask for the X-ray to see whether the patient have advanced glenohumeral joint osteoarthritis, or there may be some calcified tendinitis that account for some pictures similar to adhesive capsulitis. In some difficult case, there is certain role for the use of MRI to help you to define the diagnosis. And MRI will show some pictures that include the thickening of the coracohumeral ligament, thickening of the rotator cuff capsule, and obliteration of the fat in the rotator cuff interval, and thickening of the axillary recess. As much as I like ultrasound, and there is a review to compare the accuracy between the ultrasound and MRI in diagnosing adhesive capsulitis and show comparable accuracy. The consensus-based guidelines from both the European Society of Musculoskeletal Radiology and the European Society for Ultrasound in Medicine and Biology does not support the use of ultrasound. So I think if you really want to have some imaging to help you for diagnosis, MRI will be the way to go.
Many clinicians talk about the natural history of adhesive capsulitis in 3 or 4 stages. Can you comment on that?
Yes, still many articles, many clinicians still talk about the 3 stages. Basically, it's a freezing, a frozen, and thaw. And it gives the impression that this is the norm. However, longitudinal studies does not support this, and a systemic review also show that these stages is not the norm. I think while this 3 stages theory is not really the norm, it's not common, but it certainly gives a conceptual framework for us to think about the pathophysiology. I think there's no doubt that a lot of patients start with the inflammation resulting in pain, but the severity and the duration of this stage varies. And then they go to the next stage of fibrosis, fibrotic proliferation. Again, the severity and the duration also varies. And also the last stage, the resolution, the duration also varies. So that's why this you cannot capture with 3 boxes with a different time frame. It really can be all over the map.
So many clinicians actually believe that frozen shoulder can recover by itself in 2 years. Is that true?
There's a certain truth, but I caution about the doctrine that they will recover in 2 years without any supervision. The systemic review, they don't support this. That's number one. And number two is, I think most of the physicians who look after patient will know that with time, the symptoms get better in terms of pain and the range of movement they improve, but they are not completely fully recover. So studies show that when you examine them, they stop complaining, but they still have some residue stiffness, a loss of range of movement. It gives you the false impression they are much better, but they are not completely recover. I think the bottom line is, if you have a adhesive capsulitis, you need the treatment, you need the rehab to get to a full range of movement.
Oh, wonderful. So, how would we treat the said frozen shoulder?
Simple. The mainstay of therapy is physiotherapy, physiotherapy, and physiotherapy. There are some other modalities, but I believe that most of them is to lower the barrier to make the physiotherapy more effective. Pharmacologic measures such as simple analgesics, like anti-inflammatory, is useful in controlling the pain. Medication like duloxetine can be used for pain control as well as to alleviate some of the psychological barriers. When patients have lack of progress, they are not getting better, and sometimes we will use the interventional procedures, which we are going to cover in part 3. And rarely in some patients that recover refractory to the conservative treatment, they need to have a surgical referral, and in that case, the surgeon will consider either the manipulation of the shoulder under anesthesia, or they use a we call arthroscopic capsular release to help the patient to gain the range of movement.
Wow, that's a lot of information for today. Well, thank you so much, Dr. Peng. And for our audience, stay tuned for the part 2 and part 3 on adhesive capsulitis. Part 2 being the physical therapy and part 3 being the intervention.